Am I right that Dr. Pelican isn't here? And
yeah, he just signed the Google form, so he should be joining shortly.
Can we unmute Pauline? Is Chelsea coming?
I just was chatting with her, and yeah, she's still coming, and Pauline is actually just sending her a quick message.
Great, thanks. So we'll wait a few more minutes for people to come.
Would you like me to go ahead and start the pre-meeting talking points for instructions?
I guess you'll just keep the speakers unmuted. Am I right? So they don't have to know about it.
They don't. No,
that's fine. Then why don't you do that?
Yeah.
Thank you.
All right. Well, welcome everyone. If this is your first time joining us for one of our virtual committee meetings, you'll notice that you're muted, and you're going to stay muted throughout the duration of the meeting, except for whenever one of the co-chairs calls on you if you would like to speak. So following the presentation, the co-chairs will call on members who would like to speak from the public. If you would like to participate, all you have to do is go to the reactions icon on your screen and press the raise hand button. It's not the wave or the thumbs up, those will disappear. Only press the raise hand button once. If you press it a second time, your hand will go back down. If you're calling in from the phone, it's *9 to raise your hand and *6 to unmute when called upon. Be on the lookout for a prompt asking you to confirm unmuting once one of the co-chairs calls on you. If you're having problems, the chat is available for technical support only. It is not to ask questions or make comments to the presenters or co-chairs. They will never see those chats. If you're using an older version of Zoom, you may need to go to the participants section where you'll find the raise hand feature there. And finally, we encourage you not to raise your actual hand or wave at the screen. We may not be able to see you, and we may miss you, and we want to give you the chance to speak if you would like to. So if you're having problems, chat me. I'm here to support. And I do see that we've been joined by one of our one of our speakers. Actually, both of our speakers are here. So whenever you're ready, we can get going.
Great. I'm going to get started then, if that's okay. I'm Barbara Rutter with my co-chair, Rebecca Dangor and Wilma Johnson. This is the Community Board 8's Health Senior Social Services Committee. And we first want to thank Will for doing all the time his wonderful work that he does. We love Will and Zachary from the office that really help us out. We have had over the years a lot of meetings about COVID, from test and tracing and updates and equity and so on. And I thought it was time to do it. I am honored to be on the Community Advisory Board of the Community Board 8's representative to Community Advisory Board of Metropolitan Hospital. And I love getting the updates every month, as Dr. Pelican knows. There's always several questions along the way. So we have two wonderful experts in the field that will answer our questions. And I will say, when the agenda was written, we didn't know anything about monkeypox or cowpox or any other pox that was around. So I hope it's okay. I assume that I have some questions about it, and I assume others will too. We're going to have the presenters present, and then for a short time, and there will be questions after. I know I spoke to a lot of the new community board people. We have several, and there's some other meetings, so I think they're going to come on a little bit later. That they said, and I'm sure they'll have questions. So Dr. Pelican is the Chief Medical Officer of Metropolitan Hospital, which is a part of our health and hospitals right above our district on 97th Street and North and 2nd and 1st Avenues. He is somebody that I love listening to, and he gives us updates and has calmed us in the worst of times along the way. We look forward to hearing what he has to say. And Chelsea Cipriani, I haven't met you, but I'm looking forward to it, is the Deputy Chief Executive Community Affairs, am I right, at Department of Health. And we look forward to hearing her perspective also with questions. So Dr. Pelican, would you get started?
Certainly, I presume you can hear me.
Yes.
Yes. So good evening and thanks for having me. I'm sure there'll be some overlap between the two speakers, but that's okay. There's lots to discuss here. I thought I'd just give a broad overview and some updates with regard to the COVID virus so that we're all on the same wavelength. So currently in the New York City, especially where testing is ongoing with New York City Health and Hospitals, the nasal positivity rate for COVID is hovering around 10%. It bounces around between 8 and 11%. That's considerably higher than it had been several months ago. But I think what's important is to understand something called the R rho over R value. That R over R value is a measure of infectivity of a virus. It predicts the number of cases to develop from a single exposed person. And it's important to put this in perspective. So measles has an R naught over R value of 12 to 18. That's pretty high. It's a very infectious virus. Influenza in the winter season has an R over R value of anywhere between 0.9 and 2.1. And that leaves us with COVID-19. Where's COVID-19's R over R value? It's about 1.4 to 3.9. So clearly not as infectious as the measles virus, but more infectious than our typical influenza. So in a February 2022 CDC report, they noted that more than half of the United States population has been infected with COVID-19, including 75% of adolescents and children. Now, the proportion of infected individuals who never manifest symptoms is, I think, remarkably high at 25 to 40%. So that means those with these diminished viral loads are less likely to transmit disease, but they can still infect other individuals. These infected asymptomatic individuals do mount a highly functional cellular immune response, which is why they've been able to remain asymptomatic despite having inhaled the virus. And what's important for the population is that the greater our population has exposure to the virus, either by vaccine or by natural infection, the broader will be the immunity. So the next question is, can we completely eliminate COVID? And the answer is probably not, for several reasons. Number one, there are 29 species of animals that carry the virus, and you can't wipe out all of God's creatures. So the virus is going to be around, harboring in those animals. Number two, it has a relatively long incubation period. So again, it can be infecting an individual who can send it off to others without having symptoms. Number three, the symptoms of COVID look like the symptoms of other pathogens, and there are other viruses around. And people do get colds, and not everybody has COVID. And number four, the vaccines that we're using are not sterilizing. So they protect the virus from entering. You've all heard about the spike protein, but they don't sterilize and kill the virus. So if I'm allowed a political statement here, given that COVID-0 is not possible, the current lockdown that's going on in places like Shanghai that's affecting our supply lines is probably not going to succeed, because that shutdown is just not going to completely eliminate the virus. Now, what's different about the current BA2 virus that's affecting New York and much of the country? Well, first of all, there's a decoupling of cases and hospitalizations. Lots of cases, few hospitalizations. Number two, we have a case increase, but we do not have a concomitant rise in severe disease. So those people that get the BA2 who are not in the hospital, but may be home, are not home severely ill, for the most part. And number three, a large portion of the population already has cellular immunity. So that's helping to keep the severity of the disease down. And so we've really left the emergency phase of the pandemic, and that's why folks are talking about our entering an endemic phase. Now, what about boosters? So a couple of statistics. 33% of Americans 65 and older have completed their initial vaccine. That's the good news. But those 33% have not received even the first booster injection. That's bad news. And it's bad because the over 65 group accounts for about 75% of the US COVID deaths. Part of the reason here is that compared to the initial vaccine program, there's a little less government involvement this time in the booster program. So it's relying more on the individual and their healthcare provider to see to it that they get the booster. I think it's pretty clear that it's essential that we make the booster available to folks, for example, that live in skilled nursing facilities who tend to be a bit more elderly and have comorbidities that put them at risk. And finally, there's some disagreement about all these boosters, right? The current European recommendation is that the second booster or the fourth injection should be given to those over the age of 80, whereas in the US, the suggested age is actually over 50. Excuse me. You may have read about the Israeli study that was done. Lots of folks like myself are waiting for those final results. That was an early release from the Israeli scientists. That study has not yet been published in a peer-reviewed journal with regard to the second booster. The likelihood is that it's not going to do any harm. The real question is, will it do any good, and how long does the protection last? Whenever we talk about viruses and potentially dangerous viruses, everybody wants to know about pregnancy. You know that pregnant women are at risk for these viruses, including influenza and COVID, and they can be vaccinated. A recent study of vaccinated pregnant women showed that they had their antibodies analyzed in the latter half of the pregnancy. They have a good IgG response. That's sort of the latter part of the antibodies that respond. But their IgA response, that's the antibody in your nose that prevents the virus from sticking, that mucosal antibody was not very high in its level. Therefore, boostering these women postpartum may actually be very necessary, especially in an attempt to protect their neonate. Okay, you've heard a bit about long COVID. I mean, its formal definition is the persistence of symptoms at least 28 days after the diagnosis. Those typical symptoms include fatigue, shortness of breath, altered smell and taste, and what people like to call brain fog, that inability to concentrate, especially for long periods of time. Risk factors for long COVID include obesity, prior lung disease, cigarette smoking, diabetes, and hypertension. Sort of mirrors the folks that are susceptible to severe COVID disease. And there's a recent JAMA article that's been released that's entitled "The New Normal." So what's the new normal? The new normal is that we're probably going to receive an annual COVID vaccine the way we receive an annual influenza vaccine. Now, the current FDA proposal is the following, because you have to decide what goes into the vaccine. So the FDA is suggesting that we choose several genetic species of the vaccine, form the vaccine, give it to people in the trials, and then look at the antibody levels that are developed. Now, here's where the controversy arises. Is looking at the antibody levels in the blood really the correct measure? Shouldn't we really be looking at protection from hospitalizations and death, which is what we're really concerned about, in order to get a success from an annual viral vaccine? So more to come. You know that with the influenza vaccine, it's always difficult. It's always a best guess as to what subtypes should comprise the virus. And the vaccine experts will have that same degree of difficulty in deciding what will compose the new normal COVID vaccine. And now I thought I'd just run quickly through a couple of names. You hear all sorts of names of drugs, brand names, generic names. I thought I'd just try to put some clarity to it. The latest hot drug to be used is called Paxlovid, right? That's a Pfizer drug. It's actually the combination of two drugs. And this is a drug that can be used for folks who are 12 years of age and older and at least 88 pounds. It's actually 3 different pills taken twice a day for 5 days, and it has to be started within 5 days of the COVID-19 symptoms. I know several individuals who've taken Paxlovid. They've had no significant side effects from it, and it was their sense that it helped, although it's hard to know whether they would have just gotten better anyway, because most of those folks that I talked to had been vaccinated, right? Paxlovid stops the virus from replicating, from reproducing itself within the body. And in the trials that were done, it had an 89% efficacy against, as we discussed, hospitalization and death. That's what was done in the clinical trials. Unfortunately, there's not enough information to know about Paxlovid for pregnant women or breastfeeding women, so the recommendation is that they not receive it. If you've been around the hospital, you've heard about a drug called remdesivir. That's an antiviral medication used for people who have current COVID-19 infection. It was approved in October of 2020. It's an intravenous medication, usually used in the hospital and most notably in our ICU patients. This is a drug that actually inserts itself into the virus's genes and blocks the virus from replicating itself. It had an 87% reduction in risk of, again, hospitalization during its clinical trial. There's a new monoclonal antibody that's been released called bebtelovimab. So bebtelovimab was developed because it appears to have greater efficacy against Omicron and its BA2 subvariant. The original monoclonal antibodies, which were used for intravenous treatment when folks developed acute symptoms, was not very effective against Omicron and the BA2 variants, hence the development of this new drug. It too is approved for patients age 12 and older or greater than 88 pounds. It's an intravenous injection. We had been giving it in our emergency department. We usually have the patients hang around for a while to be sure that they have no significant side effects. And then there's an oral drug called molnupiravir or Lagavrio. That was a Merck drug that's been developed for patients who develop acute disease as well, and it's approved for patients 18 and older. It's 4 capsules every 12 hours, again, for 5 days. The recommendation is that you get it as soon as possible and within 5 days of symptoms. It blocks the virus's ability to also reproduce itself, but its efficacy was not as great, only 30% in the trials, again, measured against hospitalization and death. Molnupiravir cannot be used during pregnancy or breastfeeding. And then we have a drug called Evusheld. Evusheld is also a monoclonal antibody. This one is used for prophylaxis, right? It's a combination of 2 drugs together, and its purpose is to keep immunocompromised people who do not respond to vaccination from getting sick. It was developed by AstraZeneca. It's the first long-acting antibody to receive emergency authorization use for pre-exposure to COVID-19. It is an intramuscular injection. And its efficacy was measured at 77% and 83% 6 months after the treatment. And then finally, there's a drug you should know about called Covaxin. So Covaxin is an adjuvant, right? What's an adjuvant? That's a substance that enhances a vaccine's response. So you give it with the vaccine. It was tested and discovered by a company in, of all places, Lawrence, Kansas, but is currently in use in India. So Covaxin is in the vaccine. It travels to the body's lymph nodes, detaches from the vaccine, and activates 2 cellular receptors that play a role in the immune response to viruses. So it's supercharging your body's immune response to kill or to prevent the virus from infecting. In a phase 3 unpublished study, its efficacy is 78% against developing symptomatic disease, and it had 100% efficacy against developing severe disease. So it generates antibodies that neutralize both the alpha and the delta variants. And that's the summary of what's going on with COVID and some of its current medications.
I'm just going to ask about the bad news, bad nose, good nose that you talked about before. Is that future? Am I right? Do you want to? Is that something for the future that is hopeful?
Well, I think so, especially if they.
You want to explain? I don't think anybody else knows.
So about you. Well, if the hope is that they're going to develop the annual vaccine, then this virus will be around, but we will be able to handle it.
And there'll be a new vaccine that goes through your nose, I think is what you were saying. Am I right?
No, to the best of my knowledge, that vaccine will still be an injection.
Okay. I thought you had that bad. Remember, you talked about the bad nose, good nose.
No, right. There are some trials with a vaccine to enhance the IgA response in the nose. Those very same viruses that were found to be at low level in the pregnant women who were vaccinated. And yes, the goal there is to try to enhance the IgA in your nose so that when you inhale the virus, it's attacked and gobbled right there in your nose and never does get down into your upper respiratory tree. Yes, I haven't seen any recent literature, any further literature on those trials.
That's great. Thank you. Are you able to stay for questions?
Yes, sure.
That's wonderful. So maybe we'll ask Chelsea Cipriano if you would want to talk about.
Yeah. Absolutely. Thank you, everyone, for having me. Again, I'm Chelsea Cipriano. I'm the Executive Director of Intergovernmental Relations here at the City Health Department. Can you hear me?
Yeah, perfectly.
Okay, great. Sorry, sometimes I know with tech issues and a mask on, it's hard to know when someone's talking. So I think my colleague Pauline is going to share a deck. I will be very brief. I think Dr. Pellicone hit a lot of the high points. I'll focus a little bit more on New York City, what's going on here, what the city is doing. Right. And I know that all of you have, heard a lot of this before, but I do think just refreshing awareness of our online resources is really important because we've built out a lot of things and there's some new stuff. And I always want people to feel like they have the resources at their fingertips and they don't need me to tell them about it. They can go, find them themselves as soon as I show them, once, maybe twice. So also I think Will is going to drop those links in the chat as I'm talking about them. Okay, so we can go to the next slide. Thanks, Pauline. So this is a demonstration of the current citywide community transmission of COVID-19. What you're looking at is the new cases per 100,000 people across the city. Those of you familiar with our website know that this that you're looking at is kind of a cool hovering tool where you can click on each of these lines, which are each of these lines on this graph is a borough. So you can see, where Manhattan falls in here. We also have a tool where you can put in your zip code. So you can put in the zip codes covered by the district, which I think is really cool, and see kind of where your neighborhood falls in relation to those around it, to the borough, and to the citywide numbers that we're seeing. So this is an interactive tool. The screenshot doesn't do it justice. The thing to take away from this is, with the exception of the blip at the end, which is kind of preliminary data still, that's backfilling, we have seen very significant increases in both cases and hospitalizations in New York City recently. I think most people unfortunately know someone with COVID right now. And, while folks were really excited about spring and reopening, we are seeing this very real reality of cases and hospitalizations that have been increasing over the last couple of weeks. Next slide. This is just a snapshot of our citywide vaccine data. Again, this is all on our website. This map is an interactive tool where you can hover over each of these individual neighborhoods and see a lot of information about each. Perfect, Pauline, thank you so much. Yeah, if you were in our website, just nyc.gov/COVID vaccine, you can hover over this map. The darker areas show better coverage of vaccination. This is for people with at least one dose. Obviously, as we all know now, one dose is not enough. I think it's really compelling to see these numbers on the left. So you can see, the number of New Yorkers across all ages who have at least one dose is, well over 87%. People who are fully vaccinated, that's, 78%. It's really great. And then we get to the additional dose. That's the booster and the third dose for people who are immunocompromised and needed an additional dose for their initial series. That's only 38%. And that is not good enough. And, particularly as we're seeing cases and hospitalizations surge in the way that we are, the booster shot and staying, we call it up to date on your vaccines is what everybody needs to be doing right now. I use this great example for the holiday weekend coming up. My parents are having people over for an outdoor picnic. And even for outdoor picnic, they said, hey, it's not good enough for you to come and be fully vaccinated for our event. Please make sure you're up to date. And that signals to everyone that no matter where you are in your vaccination, series, in your risk factors, or where, your age, you need to have the number of doses that the public health experts are recommending that you have, whether that's one dose or two doses or fully vaccinated or having a booster or another booster based on your risk factors. So I just wanted to call attention to that. I think we're really focusing on how well vaccinated New York is. When we're saying that, we're talking about fully vaccinated. And on the next slide, we'll go to the next slide. We'll see what a disparity it is for kids, which I think is also really important to focus on because our youngest New Yorkers are really underprotected right now. So as most folks know, little kids under 5 can't get vaccinated yet. That vaccine has not been approved or had an emergency use authorization, though we're getting close. We're getting close. The trials, are finishing and they're submitting data to the FDA. So we're really hopeful that will be soon. But right now, even for those kids who are eligible today and have been eligible for many, many months, you can see the difference between adult coverage and childhood coverage. So for fully vaccinated among kids age 5 to 17, you can really see this disparity. If you even look further, Pauline, circling it down here, if you look at 5 to 12, you can see for fully vaccinated, we're at 47% compared to 80% for their 13 to 17-year-old counterparts. So that younger age group being under 50% fully vaccinated right now is troubling, and we need to do everything we can to ensure that parents or those with little kids in their lives know right now is the time to get yourselves vaccinated and get your kids up to date on vaccinations as well. And again, all of this is available on our website, and it's a little more interactive than these screenshots, but I wanted to give everyone a flavor of what they can find there. Next slide. This is just an additional breakdown by race and ethnicity. Barbara, you mentioned at the beginning, you've had presentations throughout the pandemic, particularly focusing on equity. I think this is something, it's not just a buzzword. We drive so much of our work on an equity and evidence basis that it's important to center this in the conversation and see what populations still are, less vaccinated than others, and looking at race and ethnicity and geographic information is all part of that. Next slide. The alert system. This is relatively new. I wanted to make sure folks were aware of it. So a couple of weeks ago, we released the COVID alert system. This is all at nyc.gov/COVID alert if you haven't seen it yet. And I believe we'll be dropping this into the chat. This is basically like a guide, a roadmap. Red light, green light. We all understand what these colors mean of kind of where we are as a city and what individuals need to do and what the government should be doing. And within each alert level, there's different guidelines, that change based on the risk. These alert levels are set based on the CDC's categorization. It's both cases and hospitalizations. So some of you may be familiar with that CDC map. That's the data that drives this alert level. We unfortunately entered high alert in New York City last week. So we immediately really tried to get everyone aware of this alert level, but more importantly, what they needed to do. Staying up to date. Wearing a mask indoor public settings is more important than ever right now. Continuing to get tested, particularly if you were exposed to someone who has COVID-19, or if you're not feeling well, of course, immediately getting tested, and before and after you travel. Also, of course, continuing really good hand hygiene. We've all kind of reverted back to, I think, to our old ways as New Yorkers of, I'm okay, I can tough it out, I can go to work if I'm feeling sick. No, we need to learn our lesson and stay home if we're feeling sick. I'm guilty of this as well. And just continuing to be very, very vigilant, about monitoring our symptoms and protecting those around us who may be more at higher risk for severe illness. Next slide. This is just a blurb about vaccination. I think folks are mostly aware now. Everyone 5 and older can and should get vaccinated right now. Booster doses are now available for ages 5 and up as well, which is very exciting. That was news as of last week. We're still doing home vaccination for anyone who wants it. That changes as of June 1st. To only those who are homebound, those who are unable to leave their home, and those over the age of 65. But as of today, you can still get an in-home vaccination with the city if you're over the age of 12. As always, our vaccines are free regardless of immigration status or the ability to pay. Next slide. Testing. We're getting a lot of questions about, home tests, availability of home tests. Should you use a home test or a PCR test, and what you need to do if you test positive on a home test? So number one, yes, tests are still available. Our amazing colleagues at Test and Trace are giving out home tests at libraries and cultural institutions all over the city right now. I walked across the street to my own public library branch. It's a smaller branch, and they had home tests, and they just gave me a bunch. It was great. So you can check the locations at this website right here, nyc.gov/COVID test. We should all continue getting testing like I was talking about before, if you fall into one of these categories. And, particularly with the holiday weekend coming up, if you're gathering before and after you gather, after you travel, really important to be testing right now to make sure that if you've been infected, even if you don't have symptoms. Really quick before we move on, I'll also touch on home testing. So if you're testing at home with a rapid test and you test positive, number one, first thing to do, isolate immediately, of course, tell folks that you may have come into contact with that, they may be close contacts and they should test and monitor their symptoms. We're getting a lot of questions of if I need to report that test to the city. The short answer is no. We have enough surveillance data from testing that we have enough data to make public health decisions, and we don't need you to call and report your positive test result. We do want you to call if you need resources, if you want to talk to someone, if you don't have your own provider, need to talk to someone about treatment. That's when you should call the 212 COVID-19 number. We're getting a lot of calls right now of just people who want to report their test, and you don't have to do that. That is not required by the city. Next slide. Treatment, touched on this, and I won't reiterate what you've already heard tonight. There are multiple forms of treatment available here in the city. We recommend you talking to your provider to see if you're eligible for treatment. Not everyone is. You do need to be at higher risk for more severe outcomes and be within a pretty small window when your symptoms started. But talk to your doctor, talk to your healthcare provider. If you don't have one, you can call 212 COVID-19 to discuss treatment options and see a teledoc. I will say, we have a program here in the city with Alto Pharmacy where you can get prescribed antivirals and get them delivered to your house same day. But many, many, many other pharmacies in the city are offering antivirals right now. There is some confusion about that. They're not the only ones doing it. When I came down with COVID-19, I got my antivirals at my local CVS. They was very quick. I got them same day and I started them that day. Next slide. And I will say one last thing on treatment, but we can stay on this slide. We really want to reiterate for folks that treatment is not a replacement for vaccination. I think I've been hearing this a lot, like, oh, well, I'll just get treated if I get COVID. The goal is to not get COVID-19, right? We don't know enough about long COVID. If even mild illness can lead to long COVID and lasting effects, not just in adults, but in kids too. So the goal should be not to get it. And vaccination really, really helps prevent not just transmission, but more importantly, severe illness from vaccination, hospitalization, death, really the worst outcomes. So don't hang your hat on being able to get treated if you get it. It is an amazing option, but the goal should be vaccination to protect against those severe outcomes before you even need the treatment. And then finally, I'll touch on this. I think, COVID trauma, we have a Legionnaire's disease, monkeypox in the news, the trauma of gun violence. There is a lot happening in our world right now that is extremely traumatic on the heels of this immensely traumatic 2 years that we just had, filled with loss of loved ones and lives and livelihoods. And I think talking about it and destigmatizing mental health and mental health needs at a time like right now is so important. NYCWell is available for folks. We have the Project Hope hotline, which is for coping with COVID specifically, and really just talking about it with friends and family and making sure that people have the resources they need. We ask that everyone help share accurate information. Misinformation is obviously a big problem with COVID. We want to spread accurate information faster than the virus. And it's still, we recommended that everyone who's eligible get their flu shot. And I think that's my last slide, but if I have one more, it'll be a fun surprise. Great. All right, that's it from me. Happy to take questions.
Great. Rebecca, do you want to see if there's questions?
Sure. Before I call on anyone, I just want to welcome new board member, Lindsay Cormack. Thank you so much for coming. And we're really excited to have you. If you, as Will said, if you have a question, please raise your hand. We're going to start with members of the public. So Boaz, can we unmute Boaz?
Can you hear me?
Yes, thank you.
Okay, first thing first, I want to say great presentation. Lots of great information, and we just need to continue. I mean, you and the team need to continue sending this data information to everyone, including community board 8 members, because I think that many people in the public and in the decision makers think that, okay, we are over COVID, and that's not true. My wife works in emergency room, and I can tell you people every night are dying from COVID, as simple as that. So all the program that we have, including the open restaurant, this is the favorite program of Community Board 8, we need to continue those programs until we are out of it. And we need to brace ourselves to a long journey. That's it. And I just want to say thank you very much for the information. I'm sad to see that we don't have enough people here, but the session is being recorded and I'm sure it will be shared with more. Thank you.
I spoke to a lot of people. There's just so many other things going on at this point. I think more people come on in a little bit because there's other meetings going on, but you're right. It's so important. The good news, I just want everybody to know, is that you can always go back to the Community Board 8 website and hear this information. So people do that when they can't come. But thank you, Boaz. Rebecca?
Anyone in the public, you can still raise your hand, but until we see any more, I'm going to turn it over to Lynn.
Okay.
So my question is that if you've had COVID, you've been boosted, you've gotten all of your shots, but you get COVID, what is the reoccurrence level? And I'm obviously still going to try to be careful, but I'm trying to get a sense of how frequently I could potentially get reinfected, like once I've had it. And I heard about that the medication for some people can cause them to re-experience some symptoms, let's say if they take it a little bit late or something like that, how do you discriminate what's from the medication reoccurrence and what could potentially be new infection?
Well, I guess I'll take a shot at that. The answer is it's very difficult. It can be very difficult to tell. I mean, with regard to the medications, except for the prophylactic medications, most of them recommend taking it within that first 5 days, because that's when you're likely to get the most benefit. If you've been vaccinated, boosted, and you had COVID, many believe that's really the ideal combination to ramp up your immune system, right? To give you the greatest protection. And you want to know, can you still get it again? Well, a lot of that has to do with what's flying around in the air. Is it some other subvariant that allows itself to attach to your nose and your upper airway and therefore give you infection? On a statistical basis, even if you get another COVID case, assuming you are in otherwise good health with a healthy immune system, then the illness that you would experience should be very mild, maybe even undetectable, right? The real risks are the folks who have compromised immune systems and have a list of those other typical comorbidities that ultimately affect their immune system. So we all live, the answer is we all live on a spectrum. And as Ms. Brianna said, the real goal here is to provide the maximum protection with the science that we currently have to avoid getting the severe case of COVID in the first place.
No, I'll just jump in. Thank you, Dr. Pelicone. I think I agree. I think we are seeing, folks, maybe some of you have friends or family in your life who are getting sick now, who did unfortunately also have COVID in December or January. I think, this is a product of variants of viruses happen, right? We know that vaccination still works against these variants. Particularly, it may not prevent you from getting COVID, but it is going to prevent those severe outcomes. And we're still seeing that to be true for these variants, but it's also why, boosters are really important, but there isn't like a hard and fast number that, if you get vaccinated, you're not going to get COVID for X amount of months. I will say one question that we're getting a lot of right now is, when should I get a second booster, right? For those who are eligible for a second booster shot, when should I get that? If I just had COVID-19. So it's kind of a user choice, but we do say, you may want to wait up to 90 days, a couple of months, to ensure that, you're protected as long as you can be. It's not a medical reason. You don't need to wait 90 days, but you can to ensure that you have some level of immunity from prior infection plus the immunity from a booster shot. So folks are really choosing what's right for them after talking to their physicians. I will speak really quickly to this rebound that folks are hearing about. I don't think I can drop it directly in the chat, but I will ask you to share this with folks. The CDC just put out a health alert last night about this kind of rebound phenomenon that people are talking about. First and foremost, people should still know that treatment is still preferred. It is still safe. It's still effective. What is believed is that this isn't like a new infection that people are experiencing, but they do need to isolate again if symptoms reoccur. And if it does happen to you, more treatment is not needed. So I just wanted to make folks aware that this is something that's being watched very closely in the CDC, and we are following, and the CDC did put some information about this out recently. And so I'll put this in the chat for folks so that they're aware.
Thank you. Rebecca.
Next, we have Meryl.
Meryl Brodsky, please unmute.
Thank you so much, Dr. Pelicone. I thought you gave a very comprehensive discussion, and it was very encouraging. Am I right in thinking that the emergency phase and severe cases are kind of over? that in fact there's eliminate 25 to 40% at least of the population, I think I got this statistic wrong, has not been infected, that we're going into a systemic stage where in fact we'll have annual vaccines every year like we would influenza, and that we're still waiting on the efficacy of the fourth booster via the Israeli study. So this is all very, very encouraging. Would you say that, for example, that the 1 out of 4 statistic is not good that the New York Times is reporting, that in fact 75% of the population has not been protected, or is the emergency phase over?
So
Go ahead, Dr. Pelicone, and then
yeah,
I'll jump in.
I'll bet Ms. Cipriano would say, yeah, it's all good news with one eyebrow up, right? It appears to be good. However, this virus has behaved unlike any of the other viruses that we've seen, and certainly far different than the typical antigenic drift and shift that you see with the influenza virus. So cautiously optimistic, yes. Cavalier, no. We have to keep an eye on the numbers, and we have to continue to try to protect ourselves with the vaccines as we're doing.
Great, but we don't look forward to another lockdown like in Shanghai. That would be a waste.
So that's sort of a different question with regard to whether the effectiveness of lockdowns that protects us from virus has to be weighed against the ill effects on the rest of society with regard to lockdowns. Probably beyond my scope, I'd say.
Okay, I was just thinking of it, what the governor might decide to do. And so far, it seems to me she's been cautiously optimistic, as you have kind of talked about. Statistics would warrant that kind of optimism, which is a good thing. Thank you.
Becca? Is there?
I don't see any other hands. Maybe if
I have a question.
Okay, great.
Yeah, we could ask questions and hopefully inspire more people.
Great. Wilma?
Yes. What I would like to know is how protected is a person if they had 2 boosters and the infusion that was given out a few months ago. What I would like to know is, do I need anything else at this point? I got the infusion and I got the 2 boosters.
Yeah, well.
Go ahead, Dr. Pelicone.
I still have to test, right?
I think you've,
that's right.
Like Ms. Cipriano would agree, she's done her homework, right? She's
Definitely.
done everything she's supposed to do.
Yes, I would agree that you've done your homework. It sounds like you've done, everything that was advised. You've gotten the treatment that you needed based on your diagnosis with COVID-19. And just for those who aren't aware, what Ms. Johnson is referencing is the MAB treatment. It is an infusion. It's different than antiviral pills, monoclonal antibody treatment. It is an infusion. A lot of folks may ask, like, how do I know whether I've had that? Ms. Johnson is spot on. It is an infusion. You will know if you've had a needle in your arm. It is a different treatment than antiviral pills. I think the real answer, Ms. Johnson, is it is unique to the individual, and there isn't like a date certain that anyone can tell you are protected until X, Y, and Z. We do know that vaccination, prior infection, these do give protection, right, to people and their immune system. But that what we still recommend is that as additional booster doses are recommended for people based on their risk level, based on their age, based on, really their likelihood of getting severe illness. I'll use myself as an example. I have pretty severe asthma, and so I'm at higher risk for complications from COVID-19. So that meant that for me, even though, I'm in my 30s, I was still eligible to get Paxlovid. I'm still eligible for a second booster shot. And I'm doing all of those things because that's what the data shows protects me best, and not just me, right? This isn't just about ourselves. It is about protecting our communities and ensuring that if we're sick and we don't know it, we're not spreading it to everyone around us. And that's why additional measures, I will say, even if you've done all of that, Ms. Johnson and others, additional measures like masks, they're still important right now. And while I share the, I want to be optimistic about the future, we are still in a high COVID alert level right now. That means our cases and our hospitalizations are high enough to put us in that orange level. That means we still need to be doing things like physical barriers like masks. So thanks for that question. Really good.
Yeah, and not to be lost in this is the totality of our care, right? I mean, everybody wants to concentrate on what to do about COVID, but there's the rest of our total body care we can't forget about, right? Everybody should have a primary care doctor. You should be taking care of your hypertension, your diabetes, should be taking your medicine, should be doing your prophylactic screening, because the more robust a machine you build in your entire body, the less will be the chances that you have a severe infection from COVID.
Absolutely. Yes, everyone, we've seen a lot of folks fall behind on, regular checkups with their PCPs, regular, like you're saying, Dr. Pellico, their diabetes medication, eye doctor visits, their kids getting vaccinated. We don't want to see our kids falling behind on their regular, measles vaccines because we fell out of care over the last 2 years. So absolutely right. I'm not a doctor, but this is my best doctor impression. Go see yours.
Can I ask a question, Rebecca? Or is it
There's
okay.
Ellen, and then we can go to you, and then I have.
Okay, great. Thanks, Ellen.
Hi,
Are you okay, Ellen?
I am good. I'm good. So I just had COVID, and it was very odd because my son must have been in that stage where he was shedding right before he became, it was obvious. And Mother's Day, and he gave it to only me. I was the only person in the whole family that got it from him, and I'm still bewildered. Like, how did that happen that not one other person got sick, including my husband? I can't, the only thing I can think of was that I was overdue for my booster, for my second booster, and I probably should have gotten it. He had gotten his. So I guess I was not up to date. So would that be an explanation of why I would have gotten it and no one else did?
So
that's one question. And my second question is, I have another question. So.
Go ahead, Dr. Pellicon, I'll follow up.
That's a possible explanation, right? Remember that R naught over R value, that one person spreads it to X number, 2 or 3 people. Sometimes it's just the luck of the draw, the chance, the amount of virus in the air that you inhaled compared to others, how it stuck to the mucosal membranes of your nose as opposed to others. Lots of unknown factors there, none of which are your fault.
I was just about to say that endpoint is really important. I think one thing that people feel, and I felt this too when I had COVID just recently, I'm still getting over it, to be honest. It's been 2 weeks. It's awful. I think we feel a lot of shame and a lot of we want to look for a reason why. We want to look where we got it, who gave it to us, and why me. And I think the answer may never be clear to us. Even if you've had a very, very close contact with someone, it was that person, why you got infected versus not is not something you're probably going to ever be able to answer, but I'm glad. I hope you've recovered, and I hope you have, the resources you need to keep recovering and not have lasting effects. I guess I'll leave it at that and encourage folks not to try to blame or look for too much reasoning, because it is unfortunately just a really terrible virus.
It was more surprising to me than I expected. Actually.
Yeah, same. No, I mean, I've been talking about this for 2 weeks. It's my job, or 2 years, to talk about this. And when I got it, I was shocked. I mean, even though I know better, it was very strange experience and very rough on my body. So I completely understand.
It's surprising. It was surprising to me because it was like my one lapse.
Mm-hmm.
I have been diligent. My one lapse was, we didn't wear masks on Mother's Day, and I actually hugged my son And that was probably, he probably has sneezed on himself. So
That's okay.
who can figure? Who can figure? So my other question is, obviously, we need to take the subway or other public transportation. Nobody, like half the people are no longer wearing masks. So is double masking enough? Is wearing a KN95 mask enough? What kind of masking will protect?
Yeah, it's a great question. Thank you for the opportunity to talk about it. Dr. Pelicone, please feel free to hop in. Number one, we definitely are recommending not just masking, but wearing a high quality mask. So that's a KN95 like I'm wearing, or an N95. That is one person wearing a mask is not as good as two people wearing a mask, right? So yes, that's what you need to be doing on the subway. If you don't have these high quality masks, not everyone does, double masking is advised. So putting cloth mask over a paper mask, 2 paper masks like surgical masks, also a good option. But these really well-fitting, high-quality masks are what we are advising in this high alert state. I will also say, if you're on the subway, yeah, I'm noticing it too. I think that's probably just, people are tired. People are seeing signals out there that COVID is over, quote unquote. I think we all know that it is not. But I think it is always ideal for there to be, if you're masking, another person masking as well. But if you can't control that other person's masking habits, you can at least control your own. So is it enough is a different question. I think we want everyone to be masking in these indoor settings like subways, where it is still very much required. Just want to, I know you know this, but remind everyone to tell their friends and families, still required on subways. But for you and what you can control within your own space, high quality, well-fitting mask.
Okay, I have one more question, and this is a show and tell. Okay, if we don't have a mask, a good quality mask, we just have the regular hospital mask, is it good enough? Is it better to do like this workaround, which I saw, to make it fit tighter? Like, is it the mask? Is the hospital mask not good because it doesn't fit tight enough to the face? Because if that's the case, there is a way. I can't, hang on a sec. See if I can get a little bit more light here. Okay, so this is what I figured out. I've seen this and I've been doing this. So it's a regular hospital mask, but I put it together here and I tie it so that it's tighter.
Oh, you're putting 2 of them together? Is that what you're saying?
No, I don't put 2 together.
You're tying the corners to fit better on your face.
Oh, so it's tighter
on my face. I tie it so that the 2 sides, so it's like this.
Yep.
And then when I put it on and then I turn it inside out and I make a pleat on the inside so that when I put this on my face, it's fitting tighter. I no longer have a gap.
Oh.
So let's see if you can see it. So I no longer have a gap against my face.
Oh.
It's fitting tighter, but it's still only a 3-ply mask. But is this better than wearing the hospital mask with the big gap on the side so that the air can get in? Or is it the same difference?
So yes, we're getting it a closer fit to your face is one part of it. I will say, surgical masks, because of the fabric and the ply, don't block very small particles. And so that's why we do recommend doubling those up, because it's not just about the fit on the edges, it's about the filtering and the material in front of your face as well, which is why, if cloth masks are down here, surgical masks, then KN95s, N95s. And really, the point of any type of mask, face covering as we used to call them, right, when people were still wearing cloth masks, is really, when you're talking about these types of face coverings, is really protecting others from you, right? So if you cough, it's not coming out at other people, whereas like a KN95 to an extent, surgical masks, but definitely KN95s and N95s are much more protective for the wearer. So they do block, smaller particles. And N95, if it's fit tested, is really, really a personal protective equipment. So that's why we recommend these higher quality. So it is both about the fit, but it's also about the coverage. And that's why we recommend doubling them up.
Thank you.
Dr. Pelican, do you wear the K95 or N95 in the hospitals? Am I right?
Actually, most recently I've been wearing the surgical mask, although oftentimes I'm in my office with only one other person who's several feet away. If I go to see a patient, I go to the bedside teaching with the students, then I'll wear a K95. I'll just put in a word as a pulmonary doctor. We do have to ventilate and breathe. So there is a limit to how much you can duct tape your face and your nose, right? You do need to breathe.
Any other questions, or can I ask mine, Rebecca?
I think you can go.
Okay, I have some of them the same as Ellen's. I had an experience. I saw the last time I had seen my son was March 1st of 2020, and he lives in Denver, and I get anxious when I think what could have been, what we didn't know at March 1st of 2020. So I saw him again this week. Needless to say, I hugged him. He was in my apartment. I wasn't wearing a mask. Of course, he came down with COVID after he left. And so number one, I haven't gotten it, which is great as far as I know. I mean, I did test and I was negative and I have no symptoms. So I guess the thing is that, am I lucky? But part two is I did have a physical, and I was told that, wow, you have a huge amount of antibodies. But Dr. Pelican, I think you were saying those antibodies may not be the test of how safe you are, or do we know what those antibodies mean? It was a blood test.
Yeah, so that was with regard to an annual vaccine, right? Because
I had the second booster.
Right. So remember, you not only produce antibodies, but you produce cellular immunity as well. Some believe that cellular immunity is particularly important. That's much more difficult to measure. That's not routinely measured in the lab. The likelihood is that you have very robust cellular immunity in addition to the antibody levels that's affording you the protection that you're enjoying.
Great. I do want to ask some practical questions. What was I supposed to do? I was told that the CDC, in fact, it was Rebecca read an email. The CDC says that you don't have to isolate if you're just exposed to somebody. Is that true? I made sure I did do an errand, but I stayed away from anybody I knew, I did.
I'm happy. I will kick this off because I want to actually bring attention to something I didn't talk about in the presentation that I did, which is the self-service tool. Will did drop it in the chat. It's a little bit further up. It's a self-service tool for isolation and quarantine. So I'll do a quick overview on isolation and quarantine just so everyone hears it, because I think it's a helpful refresher. But I do want to call attention to this amazing tool that we have from the city where you can basically just go in, note whether you've been exposed or whether you tested positive. Thank you, Will, for bumping it again. And you can say, you can see if you put in the date at which you tested positive or had symptoms or were exposed, what you need to do. It tells you how long to stay home based on your vaccination status, et cetera, et cetera. It's super, super helpful. And I think a lot of folks aren't aware of it. So please share it with your networks. It was super helpful for me, and I work in this space. I will say, so isolation and quarantine, quick refresher. Isolation is what you do if you're sick. So if you have symptoms or you test positive for COVID-19, you're going to isolate. And the length of time that you isolate differs based on what's going on with you as an individual. The length of time that is really, we say you need to isolate for COVID-19, practice good isolation techniques, is 10 days based on the infectious period of this virus. At 5 days, this is what's confusing to people. The CDC released that guidance a couple of months ago saying, at 5 days, you can leave your house, but you have to do a bunch of things. Number one, you have to be improving. Your symptoms have to be improving. You have to wear a mask at all times. You need to ensure that you're really protecting not just yourself, but others while you're out and about. If you're at that 5 days, you should still assume that you are probably still infectious. Quarantine is different. So quarantine is when you've been exposed. My lights just went out. It's okay. When you've been exposed, to a close contact, as we say. And the definition of close contact is being within 6 feet of someone who has COVID-19 for 15 minutes or more over a 24-hour period. So it's cumulative. It doesn't have to be just 15 minutes at once. And you're quarantining basically to ensure that you don't get sick. And if you are sick, that you're not spreading it around. If you are up to date, this used to be fully vaccinated, so this is an important distinction. If you are up to date, you do not need to stay home in quarantine. You should monitor your symptoms. You should test if you've been exposed to someone, but the updated guidance is that you don't need to quarantine if you are up to date. I think some folks are missing that's not just if you're fully vaccinated. You need to be up to date on your vaccines in order for this to apply to you. So yeah, I really recommend this tool. I found it incredibly helpful, and you can play around in it even if this doesn't apply to you right now, and share it with friends and family. It's in, works on mobile as well. Dr. Pellicone, anything to add to that?
No, I agree. The rules have changed several times.
It's confusing. It's confusing.
Yep. What about when should you test? I was told you have to test this time and then that time and everything else like that. When do you?
Yeah, I think we say, it is different for everyone. I'll share my personal experience because I want people to know it. I tested negative in the morning. I didn't have symptoms, but I had just traveled 2 days beforehand. So I tested because I'm following my own guidance and testing after I traveled on a plane. I tested negative in the morning. Less than 12 hours later in the evening, I tested positive and had symptoms. So it really differs for everybody. But we say, you should test after an exposure. 2 to 4 days after exposure is when you should test. Testing like right away, right that next day, you're probably not going to test positive because the infection is still building. But 2 to 4 days after that exposure, and if you test negative but you still feel really crummy, recommend retesting or going to get a PCR test.
And it should be PCR. The rapid test is not as...
It can be, rapid tests definitely are not as precise. The PCR test really is the gold standard, but many folks are still testing positive on rapid tests. They may get, like me, a negative test first and then later test positive. So that's why it's really important to be judicious and to listen to your body and to acknowledge that one rapid test doesn't mean that you are definitely negative.
Right. And then why is the city being more active in saying when you're on the subways are crowded? I am so proud of us New Yorkers. I don't care who gets shot and who gets sick. We all go on the subway. I was on the subway today and it was packed, standing room only. Why aren't we being more insistent that you should wear a mask? At least half. I wear, I wouldn't go anywhere near it without a mask, but why don't we insist on it? And Dr. Pellicone, do you agree that that's something you would feel is necessary?
Yeah, the subway is a very enclosed space with less than ideal ventilation. So that would be an area that calls for wearing a mask right now. Okay,
we need our mayor to tell us we have to do it, and we'll get fined if we don't, I think, right?
We'll say we are trying, we have a lot of messaging out there, trying to push on social media.
Yeah,
I'm happy to hear the excitement about the masks. I know, I understand. Yeah, I also saw on the subway this morning.
Right. And washing hands is still very important. The 20, we should still be singing happy birthday when we wash our hands, I assume. Am I right?
Right. Yep.
Or ABC.
Yeah.
Could we ask about the new monkey pox and the poxes?
Before we do that, we do have a hand from Boaz, but before I call on him, I just want to clarify something that we just spoke about. I was told if you and read that if you are not up to date, you should not rely on a PCR test unless you've taken it 5 days after exposure. Is that correct?
You should not rely on a PCR test.
Right. So if you're not up to date, obviously the CDC guidance is different. You are supposed to quarantine. And what, we've been getting at work is that if you have if you're not up to date, like you can't go back to the office after exposure unless you get a PCR test 5 days after. I just want to.
Right. Yeah. So that exactly. So in terms of quarantine, if you are, identified as a close contact, if you're not up to date, you do have to quarantine. And then I'll send you this guidance on quarantine as well. And yes, some workplaces are allowing people to test out of quarantine with a PCR test after a certain number of days, once they can prove that they're not symptomatic and that they are testing negative with a PCR.
Yeah. So just wanted to ask about that. Now we'll go to Boaz.
Just a small comment about the subway. From what I have heard from the experts, they are saying that the mask should be the norm on the subway, regardless of the COVID-19, right? Even let's say that tomorrow there will be super vaccine that will, that will give us a full bulletproof of COVID-19. In the subway in New York City, I mean, it's that should be now that people are now used to wearing masks, should be the norm to wear mask, to avoid flu and other diseases. Just a comment, yeah.
People aren't listening. I can say that they're just not doing it. Any comment about that, or can we go on to the?
I also would like people to listen.
Yes,
please.
Yeah. You don't stop people. There was one point I was telling people to put on a mask. I've given up on that at this point. There's nothing to do about it. Can we hear about?
I do have a few questions about COVID, if we could do those before.
Sure, let's do that. Okay.
So the first is, I'm trying to think of the best way to ask it, but I feel like there's still a very bad messaging problem when it comes to COVID. I think the difference between fully vaccinated and up to date and what that means is too confusing. And I'm wondering if you think that is leading to the low rate of boosters, or could it be that people are just kind of done, right, with the pandemic? Or even more so, is there a chance that some of the numbers are lower because you're still recommended not to get a booster if you've had COVID within like several months? Could that be adding to it? Or do you think it's really the messaging problem, or is it the exhaustion and done with the pandemic problem?
I think it may be a combination of everything. I definitely, hearing in my own circles, I will say in like my personal capacity, folks are not feeling the urgency of getting a booster shot, maybe because they just don't think their risk is that high, or they don't see the benefit. So I think we're putting a lot of time and money right now into getting more PSAs in multiple languages, particularly in community ethnic media, places on the radio. We're still saturating Hulu channels. You may not be seeing Dr. Dave anymore between every show, but you're going to be seeing Dr. Vossen. So I think we're trying to encourage folks to understand why that booster shot is so important. I think the vaccine mandates had a really big impact on people getting vaccinated. We know that from not just COVID, but that vaccine mandates really help close equity and coverage gaps. And those mandates are for fully vaccinated. They don't include booster shots except for healthcare workers. So I think maybe that, folks hear that and they think they don't need it. So I think it's a little bit of everything. We're trying to come at it from all angles, and, particularly during this surge, really hoping that folks understand that this is our best measure of protection. You don't want to get it and rely on treatment. You want to get the vaccine to try to, at least make your illness as not severe as possible. I personally don't know what this illness would have been like for me. It was pretty bad with all of this, and I know it would have been so much worse, potential hospitalization, had I not been vaccinated and boosted. So I try to share my personal experience as much as possible, because I think particularly among younger people too, they're like, I'll be fine. It'll be mild. It'll be a cold. I won't worry about it. And we don't want people to think like that, because even if it's mild, even if you have no symptoms, long COVID is a risk. We are seeing that in people who had very mild symptoms. We are seeing it in very young children. And I think that's my biggest concern. So yeah, I think we all have more work to do. I think people are tired. And I think, like I was saying, there's a lot of things going on in our lives that are distracting us from this right now.
And then before I turn it back to Ellen and then to Barbara, I have one more question, which is, again, it's kind of the same, it's similar to what I asked previously, which is there's a different feeling, right, in the air when it comes to COVID, when it comes to taking precautions. And there's one thing that I've noticed recently that's kind of alarming to me is, when everyone was more concerned about COVID and people were getting sick, and even if it wasn't COVID, because, right, people can still get strep, they can still get, the common cold, they would not go to work. I've sensed a total change. It's like, if I don't feel well and I'm sick, right, I'm speaking, in general, and I take a COVID test at home and it's negative, I've noticed, at least in my own environment, it means people feel like they need to work. Is that a problem? I think it might be, given the situation we're in right now. What can we do to try and combat that?
Yeah.
Because I will say, I was sick the other week, and I knew it wasn't COVID. I was pretty sure. I mean, you can never know. I still took tests, but I waited a second before I, called someone to be like, I don't know if I should go into the office today. And that's not something I would have done, even second guess a few months ago. So what can we do about that? And what's the best, advice you can give if you're not feeling well, even if you're still testing negative and have not been exposed?
Yeah, and Dr. Pelicon, I'm gonna call you in on this one after I respond to this. Is as not maybe all of our doctor, but a doctor. I think that we need to go back to those fundamental principles of saying, like, I'm not well enough. I should not be around other people right now, right? I should not go to work sick for my own health, because that puts further stress on your body, whether it's COVID or not, but in particular for COVID, and it does inhibit your ability to heal and recover if you're like putting that stress on your body. But also, I don't want to put other people at risk, whatever it is. If it's the flu, we shouldn't be going to work, right? The flu kills people. But I think that a lot of folks are getting very comfortable with saying, oh, it's allergies, I won't worry about it. And then going to work and not thinking a second thought about it, when that may be COVID. And even, if you were exposed and tested negative once, if you don't feel well, you need to be staying home. So Dr. Pelicon, I'll pass it over to you, but I think we need to go back to these principles of early pandemic days. I used to call them the core four, right? To help people remember them. Core four was: stay home if you're sick. Stay home if you're sick. Wear a mask, wash your hands, and keep distance. Back then it was 6 feet, still pretty good to keep distance from people. Those are the core four. They haven't changed. We've added vaccine, we've added testing, we've added treatment, but like the core tenets of this virus and of being sick in general still stand.
And before we turn it over to Dr. Pelicon,
wait, Rebecca, Dr. Pelicon may on it.
Yeah, no,
it's
just really quick. It's an additional question. The response I've heard, from people who have come to work sick, they're like, well, I'm just going to wear a mask and that's okay. To me, that I don't know. My questions are, if you're sick, should you be going to work at all? Really, mask or not?
So there are still some basic tenets related to vital signs that are important, in my opinion.
Sure.
I think if you have fever, and remember, my definition of fever is the old CDC definition, and that's 100.4 rectally. Nobody wants to hear about, but that was always fever, right? They think I have a Freudian problem with that, but the fact is I've seen too many people with respiratory infections breathing at 30 times a minute that cool off an oral thermometer. They're pretty useless, in my opinion. But if you have true fever, you really should not be going to work, both for your own benefit as well as the benefit of others, because it is likely that fever's there because your immune system is raging to such a degree it's trying to fight off a serious infection. So if you're febrile, if you have fever, you shouldn't go home. And now illnesses come in all different ilk, right? And it also depends upon what you're doing. I mean, if you have a little bit of nasal congestion and your job is to sit in your own office with a door locked and you never see anybody all day, that's one thing. If you have exposure to others and you are spewing forth sputum every time you cough, you shouldn't be going to work, practically speaking. It is unlikely you'll put in an effective day's work. It's likely that you'll become more fatigued, and it's likely that you will put others at risk. So I think there's some science and a lot of common sense to be considered.
I think we need a meeting on equity also. There are people that can't take the day off. very easily. And
Yeah,
that's a difficult problem.
It's a really important point, Barbara. Actually, I forgot to mention this. I think this really calls into question the importance of equitable policies for paid sick leave. That is a law in New York, and we know that there are so many, people who live here who do not still enjoy what is their protection under the law. And the city's done a lot to try to improve paid sick leave, even within the state, to go above beyond the state law, but we know that there's still more to be done. And so, if you are an employer, making sure that you are allowing your employees to have sick leave so that they're not making that choice between their health and the health of your patrons and their colleagues, and coming to work.
That's right.
Ellen has her hand up.
So one thing that really helped while I was sick is like every time I got into a panic saying, oh my goodness, I'm getting bronchitis. How am I breathing? It's that little pulse oximeter. Right. And it's not well known. So most people don't have these things. Is this something that the Department of Health should be telling people about, or maybe the city should be distributing them?
Yeah, and I will say, absolutely. Many actually are in the former iteration. It just changed recently. If you're part of the test and trace take care program, so you tested positive in New York City, you got a take care package. It had a thermometer, it had a pulse ox. So we did distribute many tens of thousands of these to New Yorkers. So I hope that some of you enjoyed that. And yes, I think it's something that if people are monitoring their own vital signs at home, keeping a pulse ox and a thermometer is definitely a tool that many of us have and used while we were sick.
But I assume it was an oral thermometer, am I right?
It was an oral thermometer. Sorry, Dr. Pelicon.
Well, we had our borough president on Roosevelt Island this weekend, and he was talking about possibly distributing pulse oximeters. Had the question of maybe that would be useful, and then we were talking about it. Maybe RIA could distribute it, but I'm wondering if it would be useful as a general public service for people to have it in case they get COVID. They can at least not panic that we're not going to have to go to the hospital.
So I can't resist here as a 30-year pulmonologist in the pre-pandemic era. I lobbied vigorously not to give outpatients pulse oximeters, right? Things changed a bit during the pandemic only because the oxygen level, when measured accurately, right, and not through nail polish or whatever, when measured accurately, there did appear to be an association with a particular level of the oxygen in your blood and predicting those individuals who would rapidly deteriorate from the first iteration of COVID. And that's what drove the program to distribute the oximeters. Giving oximeters out randomly for people to check, especially those with underlying stable lung disease, does run the risk of causing more panic than it does benefit. If you don't know the proper way to interpret the oximeter level in the overall clinical setting of the patient. So that's my concern about oximeter. If you knew you were going to give an oximeter to an individual who had COVID and you were looking for that 94% level that turned out to be important during the pandemic, sure, then I'm in favor of it.
What is the right way of doing it? I have it, and there was a period I was addicted to it. Not being too neurotic about it. Is there a right and wrong way of doing it? A right finger or?
Yeah, well, you have to remember that the pulse oximeter works by passing two different wavelengths of light through the capillaries, the small blood vessels in the tuft of your digit of your finger. You have to be sure those wavelengths of light get in there. They usually pass through the nail bed. That's why nail polish and certainly acrylics and wraps and tips and all that other stuff you guys call it are taboo, right? In the hospital, an old-fashioned nurse would take the nail polish off the patient, at least one finger, to be able to measure the proper oxygen level. And then you have to be sure that you have adequate circulation. You want to be sure this person doesn't have Raynaud's phenomenon with constricted blood vessels in their fingers, because you want adequate blood flow in that finger. And there is often some of the oximeters have another metric on it that tells you whether it's seeing adequate blood flow in the finger. So there are a number of things that you have to know. Ideally, if somebody instructs you on the proper way of doing the oximeter, that would be ideal.
Oh, very interesting. I never knew how it worked. Any other questions, Rebecca? You're in charge of
no, I think go on to the other.
Yeah, sure. So monkeypox.
And I heard there's cowpox also.
I am not tracking cowpox right now. That is, I will look into that as soon as I get off this call. So, and I'm sorry, I like I said, have some latent effects of COVID on my lungs, so I'm a little coughy. I apologize. So I'll do another drop in the chat for Will to share monkeypox. So monkeypox is a type of virus in the orthopox virus family. You may have heard about this in the news. It's a rare contagious disease. It's caused by the monkeypox virus. It's usually found in Central and Western African nations. Doesn't occur naturally in the US. As you may have heard in the news, there have been clusters of cases confirmed in Europe and Canada, one in the United States, in the state of Massachusetts, and there have been people under investigation as patients here in New York City. We are pending, results. We have to work with the CDC closely on this. So we do not have a confirmed case here in New York, at this time, but we are monitoring this very, very closely, including this person who is isolating, and we're doing contact tracing. So our advice, right? People want to know what they need to do, what they need to look for. If you think you have symptoms of monkeypox, which I'll go through in just a minute, isolate immediately, call your healthcare provider, and make sure that you are staying home. Symptoms. They occur 7 to 14 days after infection. Early symptoms are fever, headache, muscle aches, backaches, swollen lymph nodes, chills, exhaustion. 1 to 3 days after those initial symptoms, a patient will likely develop a rash and lesions. So that's what you've probably seen, those lesions, very common of a pox virus. It usually starts on the upper body, face, upper extremities, and then moves downward. Those can last for 2 to 4 weeks. And people need to isolate until the lesions end, until they fall off. But it is different for everybody. It's spread when people come into contact with an animal or a human being that has the virus, like other viruses. Or materials like clothing or bedding that contain the virus. It's spread through pretty large respiratory droplets and body fluids. That's what we know right now. We know the smallpox vaccine can help protect people from getting monkeypox. And right now we're monitoring the situation with the CDC, including, the potential case here in New York City, and we'll update the public as we know more. But right now, this is what we know. We'll keep you all posted. It is, of course, an emerging situation. And we want people to, know the basics and know what they need to do if they think that they've been exposed or have symptoms. But that's what I have. And I'm happy to answer questions, though I probably can't do much more. I'm not a virologist.
Yeah, but Telecom, would you know more? Can you answer?
No, I think
ahead.
that is the extent of what we know, especially in North America, where it is not endemic.
Mm-hmm.
And so when you say it's by spray, if I walk by somebody, do I have to kiss somebody, or like how close am I? somebody
It is-
sneezes on me or something like that.
Right. It's not as cut and dry. I know a lot of folks have been looking for, like, the definition of a close contact for COVID, for example. We just learned this shared vocabulary about disease. Unfortunately, it's not quite as cut and dry. It definitely requires more prolonged contact with people. So it isn't, just walking by someone is not going to be likely sufficient exposure for droplets of this size or the prolonged contact that's needed in order to contract the virus. But the key thing to know is that the cases, both in Europe, the clusters in Europe and Canada and Massachusetts for that matter, the investigation is ongoing. So they're trying to figure out, right? They're doing contact tracing. They're trying to figure out the common threads and how and why this is spreading in this way in places where it's not usually seen.
I'm going to say something that worries me. I remember very well the beginning days of COVID. And we basically said the same thing. There was only one case and it's not any more deadly than the flu. And 1 became 10, became 50, became 5,000, like almost overnight. Is there anything to worry about? Do you feel confident it's not going to quite be that way? And is it deadly? And will we need a second? I assume we all had smallpox vaccinations, I think. Am I right?
So many, I would say, just on smallpox, I believe the US stopped administering smallpox vaccinations routinely in the late 70s. So there is, I think it was late 70s, maybe early 80s when it became pretty much eradicated here. And it's really been other places in the world or people in the military who have vaccinations or healthcare providers who have had exposure. And I know a lot of first responders were also given smallpox vaccines around 9/11.
Is that the vaccine where we had sort of like back in the old days, you had the thing? Are you recommending that we get another vaccine or anything like that?
No, not at this time. No, mass, revaccination with smallpox vaccine is not recommended. I think a lot of this is we're figuring out, monitoring the situation. These, investigations of the suspected cases are ongoing. So I think it is a stay tuned and monitor the data and what we're putting out as well, and following the CDC as they continue these investigations in kind of in the United States, at least.
Have you seen, Dr. Pelican, anything in the hospital that you are suspicious or?
No, not to date. Nothing from my emergency room colleagues either.
Okay. Thank you. So we shouldn't worry too much, right? Or doesn't pay to worry?
No, it pays to stay informed, but not to worry.
And to wear your mask would help also.
Definitely wearing masks. Mm-hmm.
Good, thank you.
Yes.
Anybody
Ellen
else?
had her hand up, but I see she lowered it, so.
Ellen.
If you still have a question, you can raise your hand and we'll call on you. If not, does anyone else have any other questions?
I have found this amazingly informative, and I have a feeling in 3 weeks we may need a refresher because things seem to change all the time. Am I right?
That is the name of this virus, unfortunately. It is.
Yeah, I have several grandchildren, 3 of them are young, under 5 and so on.
Yeah.
They all got COVID, and the poor baby got it when he was 6 months old, and he was just so sick. He was just.
And I hope they've recovered.
And I wasn't there to take care of them. I wasn't thinking. It's just terrible. It really is not a good.
I will say, Barbara, happy to come back, sometime soon in the future during the summer, perhaps, particularly after approval is once we finally do have approval for little kids vaccination, the under 5s. I think that's going to be another really good opportunity to re-engage New Yorkers, and give some element of hope. I know there are a lot of parents out there who have been really waiting for this day for when their little kids can get vaccinated, and we'll do so with their pediatricians, but happy to come back and share the latest information on that as well, and give a situational update over the summer if that would be helpful.
I'm so appreciative.
We do have one more hand.
Sure.
can we unmute Lynn? And I just want to also welcome new board member Sahar Hussein. I hope I pronounced your
hi,
name
how are you?
correctly. We really appreciate you coming and welcome to the board. So Lynn?
So one of the things that I've noted, that I personally noticed just in my circle of people, is that in the I'm going to call it 3 years or 2.5, 3 years that we've been immersed in this COVID stuff, I have had more friends either diagnosed with or die from cancer than I've ever had in a single period in my life. And so my question is that just like a happenstance with my personal circle, or has the cancer rate gone up in these last 2.5 years? I mean, I've had really young friends been diagnosed with kind of unusual cancers, and is there a correlation?
Dr. Pelicon, do you want to take this one, or do you want me to?
Not that I'm aware of.
I think, I mean, and same, not that I'm aware of as well. I will say, as people are returning to healthcare after not engaging with the system for a while, we're seeing this, across the board with all types of conditions. I think people are really re-emerging and going to their provider and finding things that maybe they weren't aware of or weren't able to access care to seek. We're seeing this across the board with the STIs and other types of other, more infectious diseases. So I don't know, I haven't seen the latest data on cancers specifically, but I will say, we want people to re-engage with care because of things like this, because we want them to get the care that they need regardless of the condition as soon as possible and not delay potential treatment.
Any other questions?
No, I'll also reiterate my thanks to both the speakers and to everyone who came. I don't want to keep them, as I'm not sure if we have old or new business, but Barbara, I leave that to you.
I'll just announce next month's meeting. For whatever weird reason, the judicial system was thrown into our committee back in the days when there was nothing to talk about because everything was so safe. So we're having the DA's office return again next month just to talk about bail reform and everything else that's going on. We live in a crazy world, and thank you for coming so much.
Thank you. Have a good night.
Thank you, Dr. Pelican. We'll see you.
All right, so does anyone else have any old business? Raise your hand. Seeing none, does anyone have any new business?
No.
All right, then I guess if anyone
stay healthy, everybody.
Motion to adjourn.
Yeah.
Wilma?
All right, good night, everybody.
Bye-bye.
Barbara, this is really great. Thank you so much.
Thanks. We'll speak, Wilma.